A nurse-driven communication tool decreases delays in patient discharges by Shatandra Pell, with contributors Priscilla Biney, Kurt Kless, and Karen Pugmire. The purpose of this project is to address common barriers to patient discharges using the communication tool created by the nursing staff. The communication tool identifies the barriers to each patient's discharge, what to follow up on, and who is the person indicated to follow up with regarding each obstacle. To achieve discharges before 1400 and decrease delays in discharges. Specific aim: reduce the amount of discharges of orthopedic trauma patients after 1900 through a staff-created interdisciplinary communication tool, achieving equal to or greater than 50% of all discharges by 1400, at least 2 patients by May 1st. This project is important for the orthopedic trauma unit 5 tower because when a level 1 and level 2 traumas enter the emergency department, there is a delay in transferring patients to the floor due to late or postponed discharges, which in turn cause the emergency department to become overcrowded daily. Recently, at Atlanta Medical Center, where this setting takes place, we have been at full capacity. The emergency department has been at full capacity, and each floor has been at full capacity. So we have a full capacity protocol that encourages everyone to expedite discharges. This happens often. Forming a team. When developing my team, I chose those who were leaders on my unit and those who could foster change within their job description. I decided to utilize members of our interdisciplinary team that had similar goals and expectations for patient-centered and quality care. Team members collaboration. The team members chosen were all those in all disciplines who could contribute in identifying and overcoming barriers to discharges. Priscilla Biney. She is the nurse manager on 5 Tower. Kurt Kless is the director of nursing of 5 Tower. Karen Pugmire is the trauma nurse practitioner for 5 Tower, and she is a key role in getting discharges, discharge orders, lab results that are holding patients, any type of test that's holding medical clearance. She is definitely a pivotal role in that. James Stanford, core management, bed control. He is the person who gives us the geometric length of stay, the actual length of stay. He also lets us know what needs to be documented for insurance purposes, if a patient is inpatient versus observations, what type of insurance they have, HMO, uninsured, several things. Octavia Buckingham is the director of case management. At the beginning of this project, she was a case manager and then progressed to director of case management and has played a pivotal role in this project and also trying to decrease length of stay throughout the entire hospital at this point. And we also include all members of physical therapy and occupational therapy. There wasn't one person in particular that contributed to the project. They all contributed to the project because we hold our interdisciplinary rounds meeting, IDR, Monday through Friday, and physical therapy is always present. Physical and occupational therapy are always present to tell us the status of the patient's mobility, and if they're cleared by physical therapy, why they haven't been cleared from physical therapy, and who doesn't have orders and needs orders for physical therapy to be discharged. Change concept. According to Kurt Lewin's stages of change, you have to unfreeze team members' current perspective by including transparency as to why the change is necessary. Secondly, implementing the change, allowing time for team members to adjust and ask questions about the change. And finally, freezing the new practice expectations to ensure team members do not regress to previous practice. Stages of PDSA, Plan, Do, Study, Act. Our plan was to test our nurse-driven communication tool to decrease delays in patient discharges. We had charge nurses use communication tool during interdisciplinary rounds. We studied, is the communication tool discharging greater than or equal to 50% of discharges before 1400? What are the barriers? Act, addressing one lagging measure at a time, physical therapy clearance, transportation, discharge orders. So as far as our PDSA, the communication tool definitely increased communication between all disciplinaries. We found that our lagging measures include physical therapy clearance, transportation, and discharge orders, and that's why we included the team members that we included into the project, because physical therapy clearance would be dictated by physical and occupational therapists. Transportation, sometimes we can get bus passes for patients who don't have transportation. We can set up Medicaid vans for patients who don't have transportation. We can even sometimes set up Uber or Lyfts for patients who don't have discharge, and case management plays the biggest role in transportation issues, and those who need to go to skilled nursing facilities, subacute and acute rehabs, and need transportation to those things. And of course, the nurse practitioner, Karen Pugmire, plays the biggest role as far as discharge orders, because she is our liaison between the residents, the attendings. So whenever we get clearance from physical therapy to discharge a patient, we can call the nurse practitioner and ask her if this patient is okay to be discharged because they have seen physical therapy and physical therapy has cleared them. She would then dictate if the person is medically cleared, and if they are, she would then put in the discharge orders for the patient to be discharged. So there's a lot of communication that needs to happen to have patients be discharged on time. Implementing and creating change. So to implement and spread change, we announced the communication tool during our daily huddle at 6:45 in the morning to include both day and night shift. We spread and implemented the change with our interdisciplinary team during IDRs to empower our staff. We discussed weekly reserves during our daily huddle. This way that we could encourage them to discuss discharge planning at the bedside during bedside shift report. Several articles and evidence-based research has said that bedside shift report increases communication between nursing staff and the patient, and engaging the patient in the bedside shift report fosters awareness. So we thought it would be best to share the weekly results with the nursing staff during huddle every week, so that they would see how the communication tool is increasing the likelihood of patients being discharged on time, and then we wouldn't be at full capacity. That would be the goal, and then the emergency department wouldn't be at full capacity, because it's like a domino effect. Impact on practice. Okay, so when we discuss our specific aim to reduce the amount of discharges on the orthopedic trauma patients after 1900 through a staff-created interdisciplinary communication tool achieving equal to or greater than 50% of all discharges by 1400, at least 2 patients by May 1st. We have a chart here at the bottom that lets us know where we stood throughout the project. So in February, we had 42 patients discharged before 1400. And a total of 161 patients totaled in the month. That gave us 26% of patients that were discharged before 1400. This was at the start of our project. So the start of our project, we wanted patients to be discharged before 11, and we were not successful in the upcoming week. So I decided to change the aim to 1400. So we had to go back into February and get the data. So we stood at 26% of those patients being discharged before 1400, which obviously is not successful. As the project continued and we implemented the changes that we said we would do, in March we had 80 patients discharged before 1400 out of a total of 202 total discharges for March. That gave us 39% of patients discharged before 1400. So at that point, we had about a 13% increase in patients discharged while using the communication tool. And with this information, it encouraged me to continue the project at 1400. And then, of course, April, last month, we had 82 patients discharged before 1400, with a total of 166 patients discharged total within that month, and gave us 49% of patients discharged before 1400. Now, that is definitely an increase in where we started at 29%. Unfortunately, with the specific aim, we did not get equal to or greater than 50%, but I truly believe that if the project continues and we continue to use the communication tool, that we could definitely achieve that goal on the unit to increase discharges. We found that majority of our patients, their barriers to discharge was transportation. They didn't have their transportation set up with their families, and this person was working until 5. So a lot of those things played a difference in the discharges. And I say that, it's not necessarily a modifiable barrier to discharge, because we cannot control how patients set up their transportation. My goal was to have bedside shift report discuss the discharge at the bedside with the patient and let them know there's a possibility that you could be discharged today. We encourage you to plan out your discharge, have someone come get you. We would like patients to be discharged before 2 p.m. And then the patient, may say, my husband doesn't get off work till 5 o'clock. So those are the things that were holding up the patients majority of the time. I definitely read a couple of articles about evidence-based practice and using bedside shift report, as well as the whiteboards that we do have to encourage communication between nurses, staff, and patients regarding their discharge. And our communication board, our whiteboard, has discharge information that we do input onto the board to keep patients updated and informed on their discharges. But again, we can't control whether or not their families or whoever can discharge them before 2 o'clock. And also, I found out some information. A couple of local hospitals in the Atlanta area have discharge lounges for patients who were medically and safely able to go to the discharge lounge once they've been discharged, and all they're waiting on is transportation. But my research didn't go into depth about the discharge lounge. It would be definitely something that is interesting to read, but we don't have that implemented at our hospital currently, and possibly could benefit from that. But as of right now, with the project, it was not successful in achieving the specific aim of the project, but we definitely increased communication between nursing staff, patients, and the interdisciplinary team regarding our discharges. So that was a big win, despite not discharging 50% of all discharges by 1400. The chart is available to read, as well as the references. Thank you very much. I hope you enjoyed this project, and have a great semester.